Thanks everybody for showing up. I know it's Friday and everybody's like wanting to just get ready for the weekend and get out of a weekend mindset. What I wanted to talk about today is really exciting because this is the first of the talks that how to really get the Brainwell program working for your patients, because it has to start from somewhere. So I wanted to talk about what labs I order and what biomarkers I use to determine what we call the Brainwell Comprehensive Treatment Plan, which is what patients get after they do all this workup. I'm not even sure how many biomarkers those are. Just in the hormones alone, it's about 28. So who knows, maybe it's about 65 that we finally go through. So, but haven't counted it. I just do the orders. So what I wanted to discuss to relay this is a segue into, this is part of the Brainwell program, basically the ingredient of what makes me come up with a treatment plan for my patients. We start with the genetics, and then we look at other labs aside from the hormone panel, and that will determine what supplements we tell patients to take. And then this will also determine what supplements a patient takes if I tell them that they have to do TMS based on their genetics, as well as their labs and vitamin deficiencies and so forth. And the labs will also determine what supplements I give to patients who want to do hormone replacement, but really more with a natural edge to it, instead of just being reliant on medications in the long run. The whole basis of figuring out what the labs we order and biomarkers we order is really based on precision psychiatry. And that is using biomarkers and labs to get to the root cause of the psychiatric symptom. So we know about traditional psychiatric treatment. We focus on DSM, and then we focus on, what the symptoms are, what the disorder is, and then we give the pills from figuring out what the psychiatric problem is. However, with precision psychiatry, we kind of turn it upside down. What we need to do is look at all the biomarkers and then determine what to do with a patient. Is it supplements? Is it medications? Is it therapy? And then that way we are providing the patient a overall comprehensive mental health solution, not just treating the symptoms or the syndrome. One of the reasons why I delved into this journey of what else I can do to get my patient better, because in psychiatry, we're not even really taught in standard psychiatric practice to do a full workup, maybe just the basic things, but having the background with internal medicine and psychiatry, I always relied also on making sure my patients' thyroids are good, vitamin levels are good, because what happens with standard psychiatric treatment, we have such a thing called treatment resistance, and that is patients who are unresponsive to traditional treatments. And really, it's all about medication failures. Treatment resistance is anywhere between 30 to 55%. When I say 55%, I really believe it's closer to that, because this is based on the STAR-D study, which is the mother of all studies when it comes to analyzing every psychiatric medicine out there. They go through this protocol of giving this med. If that doesn't work, you try this med, and it doesn't work, try another one. It doesn't work, adjunctive. But at the end of the day, they still had a 55% failure rate. So that's pretty scary, with people coming to a psychiatrist thinking that they're going to get full relief of their symptoms with just one medication, second or third, or adjunctive. And in anxiety, treatment resistance is 50%. OCD, treatment resistance is 50%. ADHD, treatment resistance is 25%. And bipolar disorder, the worst part of the disease is the depression, because this is where people at high risk for suicide, 2/3 do not respond to standard psychiatric treatment. So, and what's even worse is that sometimes if the patient gets the wrong treatment, what happens to the patient? The brain changes, not for the best. The episodes could get worse, and episodes are going to become more frequent. So, beyond this, other challenges are besides the patient dealing with these issues, the loved ones, the caregivers, and society are also affected. So, in terms of the biomarkers and what labs to order, this is what I use to guide my supplements, what lifestyle to tell the patient to do, whether they need therapy or not, or whether kind of therapy they need, as well as are they going to benefit from TMS? And if they are going to benefit from TMS, what do I need to do to prepare their brain so they can respond to TMS and have a longer lasting result with TMS, as well as the biomarkers will tell me which direction to go with hormone replacement. Do I really have to do testosterone injections, or can I just replace the things that come before testosterone? Or even then, do I need to support the brain for healing? And there's something that we look at in those biomarkers that tell me which direction to go, even for hormone replacement. And then at the end, yeah, I may use psychiatric treatments and medications. I have just a variety of patients who have responded to the brain mode program. Some of them are on maybe several antidepressants, but they tell me, doc, don't stop them. You know, whatever you added, now they're working, so I'm keeping it. And then I have patients saying, eventually I want to just get off my Prozac or fluoxetine. And I say, okay, you know, we will work towards that goal. So I'm not ruling out psychiatric medicines, but I want to know, is there something going on in them that we can try to support before we wind up having to do psychiatric medicines? So in terms of ordering labs, the top three things I do is genetic testing. And then I do what I call my brain mode panel. The brain mode panel is broken down to a depression panel, and then also to know my neuroendocrine panel. I mean, that's what people know as hormones, but I really would like to emphasize that this is not just about hormones. I'm looking at your brain hormones and how it connects with the rest of your hormone system. So we know whether the deficiency is coming basically from the periphery, or is it coming from the brain, from a brain injury or COVID or strokes, or any kind of infections as well. So let's talk about genetic testing. There's two things that we have to look at with genetic testing. I think we all know how everybody thinks of genetic testing is that, you know, you got to, you know, give this medication because this one works the best, and, you know, versus this and so forth. And that's how I started with genetic testing. However, I found that with genetic testing, if I am not looking at things like pharmacokinetics and especially pharmacodynamics, I'm missing a big piece of the pie in what else I can do to get my patient better, other than choosing a medication in that, you know, green, yellow, red column. So in order to understand genetic testing, we got to understand the principle of pharmacokinetics. These are how the drugs move within the body. As you can see, these are the genes, you know, the CYP genes and UGT genes. These are all like, sort of like how the drug moves to the body, and like whether it's good for us, or whether, you know, we need to give a higher dose, or make sure we don't give this other medicine with it because you'll have a drug-drug interaction with it. And these are the principles, and based on what the drug does to the body. And these are the things we have to consider: absorption, distribution, metabolism, and excretion. However, I lean heavily towards pharmacodynamics, what the body does to the drug. These are the effects of the drug and their mechanism of action. If you can see to the right, these are all the different pharmacodynamic genes. And to me, I think it's more important for us to also not dismiss this, because if you look at it, if you see that towards a little bit to the bottom, it says HLA, okay? And then HLA and HLA-B. This tells us what drugs to absolutely avoid in patients because of certain reaction that can happen, which is the reason, the rationale why we have to be careful with lamotrigine. But as you can see, these are the ones with the issues with receptors and synthesis of certain neurotransmitters. So in this, we do think about what is the interaction between neurotransmitters and their interactions with receptors and transporters. Really, the principle behind when you talk about transporters, that's the principle between a serotonin reuptake inhibitor, and that's what they use. Okay, so let's talk about pharmacokinetic dynamic genes. The top three I really look at is BDNF, MTHFR, and COMT. I think everybody's heard me talking about this, but this is one of the reasons why I think BDNF is really important, particularly with brain injury. Some of the functions of BDNF increases neuronal survival after brain damage, whether it's TBI, strokes, and so forth. You notice that some people can recover from a stroke even if they are paralyzed. The BDNF is responsible for making that happen, as well as neurogenesis, also creating new brain cells, and migration and differentiation of neurons. And there's not just one type of brain cell, there's all different kinds. And then the growth of dendrites and axons. Connectivity between brain cells is very important because the brain cell is, not by itself, it's not an island. They have to communicate with each other through neurotransmitters. Otherwise, the brain doesn't function, the brain doesn't work. And then synapse formation. So that's also part of the communication between two brain cells. When it comes to looking at genetic testing, I say it's very important that we have a genetic test that does look into the BDNF, because if it's heterozygous, this is the one that you usually think heterozygous is good and protective of us, but heterozygous is actually not so great here because it can decrease the BDNF synthesis versus something that's homozygous, which you have normal BDNF. So the MET carriers are the ones that have low BDNF levels in the brain. And some of the symptoms of BDNF is you can have depression, you can have mood instability, you can have anxiety, you can have cognitive impairment, as well as inattention. So really, it's all about the brain cells not being healthy, and as well as memory loss. MTHFR, I think everybody knows all about this, but I wanted to just reiterate the importance of it. Okay, so here is the cycle of making all the neurotransmitters, serotonin, dopamine, norepinephrine. So it starts out in regular cycle, the folate vitamin goes through the MTHFR enzyme, and out comes L-methylfolate, which is what it has to be in order to be useful in making our neurotransmitters. So, the second circle, L-methylfolate with methionine becomes SAM-E. And then depending on which way you go, in the top, you add tryptophan, it becomes serotonin. But on the bottom, if you add tyrosine, it becomes dopamine that then breaks down to norepinephrine. However, if you don't have a good MTHFR activity, you got this buildup of homocysteine. And what happens with homocysteine is very toxic to the brain. And these are the things that happen if you have too much homocysteine. CNS inflammation, suppression of even neural stem cells, so you can't even make nerve cells. Toxicity, the vasculature in the brain, apoptosis, as well as oxidative stress, impaired myelination, meaning, how well is the brain protected, as well as plaques and tangles. As we know, that's like one of the pathologies in dementia. So it's very important we understand why MTHFR deficiency and how it affects not only our neurotransmitters, but how the homocysteine level is, if it's elevated because we have this deficiency, and what kind of effects it has on the brain. So not only are we depressed, but we can be prone to things like dementia, memory loss, and forgetfulness, and so forth. The second thing that we look at is the COMT gene. The COMT gene breaks down dopamine as well as estrogen. So people really put a lot of emphasis on the dopamine, but don't forget, estrogen is also part of this. So think about if somebody is low breakdown of estrogen, you have higher levels of estrogen. And even before I even know what somebody's genetics are, if I see a male or a female, especially a male, I'll be like, why is your estrogen high? And I'm already suspecting this. And these are, people that are more prone to emotionalities and frustration tolerance. So in the brain, the dopamine comes in, the COMT enzyme breaks it down to, now it's degraded. So you don't have too much dopamine that is building up in your brain, that's causing you anxiety, as well as low frustration tolerance, as well as mood instability and really, really high anxiety. Those are the things that happens when the COMT gene is not working very well, if you don't have enough activity going on. So one of the things that we need to understand, the COMT gene can go one way or another. It's not just one thing. When you talk about a low COMT activity, that means a low metabolism of dopamine and estrogen, leads to high dopamine. You worry, you're anxious, you're obsessive, you have poor stress tolerance. You can have psychosis because you have too much dopamine in the brain. And these are the ones that don't like change, and they get really upset if there's some changes going on that it totally throws their world off, because they're so used to having such obsessive compulsive organization. If you throw a wrench in there, they're not happy. And I think everybody knows these kinds of people that you've worked with. But just understand this is how they are, and then let them spew, and I think they'll be okay, hopefully. Especially if you can understand really certain people's personality, that genetics can influence them. So if you have a high estrogen, they're moody, they're overreactive. These are the women that I often ask, what do you like before your periods? Oh, doc, I'm awful. It's bad. So yeah, because they will not metabolize the estrogen as well as somebody who doesn't have that issue. So, but there are good things about the patient. When you're balanced, you have good executive functioning, they're reliable, they're the go-to people. When you need help with projects, they'll get it done and they'll get it perfect. So there's not always just bad things, there's good things about these people. So these are the things that you see the low COMT gene in: anxiety, social anxiety, panic disorder, OCD. They have to have everything all perfect, or else their world is just right. Autism. I've seen this gene with people who have been diagnosed with autism, because extremely high anxiety, as well as PTSD, bipolar disorder, schizophrenia because of the high dopamine levels, PMDD that can occur as well, and postpartum. So these conditions not only affect the mental health, but as well as somebody who may have gone through some kind of menstrual irregularities or postpartum and so forth. And the opposite is what we call the warrior gene. This is diagnosed with CC, VAL, high metabolism of dopamine and estrogen. So leading to what? Low dopamine, low estrogen. They function great in chaos. They are great multitaskers. These are the people that you want in crisis. These are the people that are the high functioning CEOs that can come in and rattle off any kind of solution when their people are just coming to them with this and this and this, and they can just say, hold up, A, B, C, D, this, and everybody's happy because they came in and they quote unquote saved the day. And these are the ones that are more common with police and first responders and ER workers. And we need those people, because when there's chaos, it seems like this is how their dopamine gets released, because the body and the brain is commanding them to, you got to make this, or else you're not going to be in a position where you can solve these issues at hand. Unfortunately, when it comes to these people, they do have inattention, depression, and you can have apathy. The reason being is that they run low in dopamine. So this is what I call the ADHD gene. And this is how they actually title it when it comes to genetic testing. Okay, I want to test for all the depression, anxiety genes, and I want to test for ADHD. This is one of the things that they do test for. So interesting to see that there is a biologic basis for ADHD, not just, they run low in dopamine, but now we have the answer why they run low in dopamine. It's in their genes. And these are the things you can see: high COMT, depression, anxiety, ADHD, impulse control disorder, gambling, binge eating disorder, substance abuse. Why? They're always chasing that dopamine. And because their brain is telling them they have to do that. They can't sit still because of the fact they need dopamine. And when you move and you exercise, the dopamine gets released. So other things that we look at in your pharmacodynamic genes, I call this GRIC1. It's very important that a genetic test you use does test for this, especially with somebody with alcoholism. The GRIC gene is very important in alcoholics. And then these are the patients that respond better to Topamax. I had a patient that had this thing. She was a bad alcoholic, and I added the Topamax. She remained sober from alcohol use. And then so I think, okay, you're doing good. Maybe we don't need this anymore. I took it off. Oh, she went back to drinking with a vengeance. So I said, okay, you're never coming off this thing in order for me to help you stay sober. And she was fine with that. In fact, she even got depressed when I took her off the Topamax, because I was, she was also okay with it because she'd been sober for a while. So look for this gene, and if it has any significance, and if they are alcoholic, topiramate is a great option for them to stay sober. And that's why they've shown studies sometimes that topiramate will help alcoholics to stay sober. ANCA gene, this is the sodium channel gene, meaning if they have issues with this, mood stabilizers, the ones that modulate sodium, which are the basic seizure medications, Depakote and so forth. These are the people that will respond better to mood stabilizers over somebody else that doesn't have these issues. The calcium channel gene, CAGNA A1C, this is very, very fascinating to me, because these are the people that may not respond to anything you give them. I have one case actually that I had to resort, because she had this abnormality, to a calcium channel blocker. I think I gave her amlodipine or nifedipine. Stable with her anxiety and stable with her mood instability since then. I'm not against using other options. But understand that, these genes can actually help guide where and what kind of medicines you should use, even medicines outside of psychiatry that can help people stay stable or get stable with their anxiety. Steven Johnson's, this is the one that we really, really have to pay attention to. I know a lot of people don't even look at this part of the pharmacodynamic gene. However, this is very dangerous. So I do look at this. If somebody is HLA-A plus positive, they will have a propensity for Stevens-Johnson syndrome to carbamazepine, which is Tegretol. But there's another gene that is also highly, highly prone to Stevens-Johnson syndrome. So in these cases, we have to check this among especially Asians, because they have a high propensity to have this deficiency or this abnormality. This one, HLA-B1, avoid all the seizure meds, pretty much, including the phenytoin. But this is really the basis of why we have to be careful with lamotrigine. So now we understand why we have to do things slowly with lamotrigine. But isn't it great? We have a tool that can tell us whether we just avoid it or we can go a little higher on it. And it's not going to have a problem with them developing Stevens-Johnson syndrome. The next couple of genes that we're going to talk about is ADRA. ADRA is good to know. The reason being, this is sort of related to the ADHD gene. This is what will determine whether the patient will respond better to methylphenidate versus amphetamines or dextroamphetamines. As we know, this is a Ritalin or Concerta. Are you going to go with more of the Ritalin base or more of the Adderall base, amphetamine base? This will tell you which direction to go when you want to treat people with stimulants. The DRD2 gene, these are the ones that, if it's abnormal, they may need higher dosages of antipsychotics. But the problem is, when you have higher doses of antipsychotics, especially atypicals, these are the ones that are going to be prone to weight gain. The OPRM1 gene, this is the opioid receptor gene. And we don't know what people's genetics are when they walk in through the ER, or when they're in the hospital and they need pain medicines. But if I do know this about a patient, they're going to go in surgery. And I will warn them that maybe they're going to need more pain medication than others. And sometimes, the doctor will just dismiss it, but there is a genetic basis for it. And let's go through the serotonin receptor gene. This is very important because depending on which way it goes, if you have a good one, then you are going to respond better to SSRIs or not. Are you going to be more prone to their side effects? There's two receptors for serotonin. This is the 5-HT2C. And these are the ones, if it's abnormal, they are going to be more prone to weight gain with antipsychotics. And the transporter gene, this is the basis of the serotonin receptor uptake inhibitor mechanism. So this is, you can tell whether they are going to respond well to SSRIs or not, whether they're going to have more side effects. And then the MC4R gene, as we know, MC4R is very important in appetite control. If abnormal, they're going to be more prone to weight gain with antipsychotics. The genetic testing companies, maybe at the end, we can really delve into each one, what they look like. I prefer Genomine. The reason being is they test for everything that I've discussed, but they test for the top three things that I look for. The MTHFR, BDNF. It's very important. I need to know this when it comes to people who've had history of brain injury. And I'm finding that 9 times out of 10, my patients have a brain injury, whether they realize it or not. I need to understand this. This also gives you an understanding of why some patients with brain injury will recover better than others. And of course, the COMT gene, I need to know that because it implicates not only in ADHD, but in also mood disorders. So this other one, Pure Genomics, there's good things to it. It uses raw data from Ancestry or 23andMe. It has all 3 genes and more. I mean, this is really what people use when they talk about nutrigenomics. Cons are, they're a little difficult to read. However, and because I have to actually have a little cheat sheet with me to try to figure out, because they don't always use the same genetic markers as what Genomine uses, because Genomine is pretty much straightforward. This is what it is. But you can find some really good information in there, and especially with people who are like needing more vitamin D and all kinds of, those kinds of things. GeneSight, they test for only 2 out of the 3. It doesn't have the BDNF, so it's not very useful in patients with brain injury. But when it comes to cost, and if they don't have that history, then I kind of humor it. But what do I do in these cases if they have a brain injury? So I usually just still tell them take some lithium orotate to see if their focus, concentration gets better. If it doesn't, then more than likely they don't have it, because I see this response in my patients who have the altered BDNF. They just take 5 milligrams of lithium orotate, and a month later they notice that their brain function is much better compared to not taking the lithium orotate. And so you don't have to go with like lithium carbonate, which is the higher lithium, which is more of a pharmaceutical lithium, which is a little bit harmful to the kidneys if long-term, especially if you keep it therapeutic. So later on, we can come back to that and look at some samples of what each of those three look like, okay? The Brainwell labs, this is what I call my Brainwell panel, consists of things, basic metabolic workup, vitamin and vitamin metabolism levels, my inflammation markers, toxins, as well as my neuroendocrine markers and what we call as hormones. In the basic metabolic workup, you have your CBC with diff, your CMP, and your metabolic labs. We look at lipid panels and hemoglobin A1C. These are all important anyways for me, because what if the patient is just having issues with anemia and that's why they're tired? I need to know what their kidney functions and liver functions are before I start going on about like taking supplements, because you have to be careful with some supplements like turmeric. You have to be careful or probably avoid if somebody has renal issues. And of course, I want to know what their lipid panel looks like. Not only if I'm that concerned about whether it's high, but really if it's low. That can explain why somebody could be depressed. And hemoglobin A1C, if you have to put somebody on an atypical antipsychotic, we need to monitor that. And of course, the drug screen, especially with people who have addiction issues, we got to have that in place. Or, if somebody comes to me for weight loss, and I need to have that in place to make sure if I do have to give them a diet pill like phentermine or phentermine, I need to monitor that as well. Okay, so vitamin levels, I check for vitamin D. Vitamin D is very important, not only in depression, but it also Hashimoto's thyroiditis. If it's low, the Hashimoto's thyroiditis is actually increased. And then I've had a case where the Hashimoto's enzyme went down after I supplement their vitamin D. Iron, we need to know, are they fatigued because of that? Zinc, and I'll explain a little bit of that later when it comes to the endocrine panel. And magnesium, lower magnesiums are people are more prone to anxiety. And the B vitamins is really important because as I showed with the MTHFR cycle, B vitamins is important in everything, the B12 and the folate and all those other things, the B6. So the things that I do look at, of course, is the folate level. And then what happens to the homocysteine? And homocysteine, if it's up, it's either B12 or folate deficiency. I still also look at the B12 level because sometimes if it's not optimal, like below 400, and the patient is complaining depression and fatigue, I try to get them somewhere into the middle. But methylmalonic acid is specific for B12 deficiency. The reason being is that it's really important because of if your B12 is high and your methylmalonic acid is high, that tells me that, hey, maybe they're not metabolizing B12 very well. Very, very common with people who also have MTHFR deficiency. So some of the things that I do in these cases, just to hit everything, a lot of the B complex, something from pure encapsulation as well as life extension, they already are the methylated form of folate and the methylated form of B12. So that kind of just negates all that. But still, we need to know this, whether can they just take a regular B12 or can they take a regular folate? Yeah, I will find though that even if they don't have MTHFR deficiency, but their homocysteine level is elevated, I may still give methylated folate because there's something else going on that could also cause the folate vitamin to not metabolize to the active form. Okay, so inflammation markers, I look at the CRP. This is not specific, but this will tell me, like, is there mental health issues related to inflammation? And then one of the things I look at is Epstein-Barr virus, not so much to say you have mono, is what, the people notice as the kissing disease. And most patients get surprised, I had mono. And then it's like, and I tell them, no, you're not active, you're not infectious, but something is making those markers go sky high. I don't know why, but then that's when sometimes if the patient can have the ability to afford themselves a tox panel, then that'll give me a better, clearer answer what's causing the inflammation. So it's very important that we also do check for Epstein-Barr virus, the titer, because it can cause chronic fatigue and myalgia, and we don't know why. They're tired and they look depressed. But we found out a study that came from Stanford in May 2021. 40% of people who have, in their childhood, mono, they have a risk for depression. And essentially, it really is due to inflammation. So the tox panel, the top 3 I look at are the heavy metals, mycotoxins, not so much the mold, but the toxins that release from the mold that causes chronic inflammation. And glyphosate. Glyphosate is what's in Roundup, and that can cause havoc in your neurologic system, especially in the cells. It is very toxic to the cell. So the tox panel that I use, that I've started to go into now, is called Vibrant Wellness. And I learned this from Dr. Lou. Thank you for showing me this, because what I like about it, it does everything: heavy metals, mycotoxin, glyphosate, which is Roundup, and BPA. As we know, BPA is a high risk factor for breast cancer in people who don't have a familial likelihood to get it. This is good to know, even with people who want to come to me for HRT. And some people, I do have to give estrogen, and then they look like they have low estrogen. And then the minute I give it to them, they're complaining of breast pain. And I'm like, that is just bizarre. It's because BPA is an endocrine disruptor, acts like estrogen, sits on an estrogen receptor, just like if it was estrogen, but their levels look like they're low estrogen. So I've come to a point where, like, if somebody comes to me for HRT, I need to do this workup. And if I see inflammation, I say, hold up, this is not something that I want to do on you before, right away. I need to get you cleaned out so we're not having endocrine disruption. So the other lab that I do is Mosaic. This is what I was using a lot before. This has heavy metals, mycotoxin, glyphosate, but no BPA. I had my assistant look into this for me. If somebody tells me that I'm wrong, so let me know. These are some of the examples of the reports, but we'll go through that at the end if we have the time, okay? So glyphosate, what is wrong with glyphosate? Glyphosate is neurotoxic. AMPA is the metabolite of it, and it causes oxidative stress, inflammation, basically kills the brain cells. And you can have problems like Parkinson's and looking like you have stroke-like symptoms. So it also disrupts neurotransmitters. It basically stops glutamine from making glutamate, which is your excitatory, as well as GABA, which is your inhibitory. So you have nothing there. It also will deplete dopamine. So what happens when you don't have dopamine? We all know about that. And then it also then builds up your serotonin. And that's why these people look like they're just so blah and apathetic. That's what happens when you have too much SSRI. You have apathy syndrome. The last thing we look at in a brain well panel is the neuroendocrine hormone panel. We look at your pituitary hormones, luteinizing hormone, FSH hormones, TSH, ACTH, and your growth hormones. And let's go back to LH and FSH. LH is very important because this is what will tell me if the low T is due to brain injury or not. TSH, that's your thyroid hormones. ACTH, that will help promote the cortisol, and growth hormone coming from the pituitary gland. We don't necessarily check for the growth hormone. We're looking at the binding protein, and IGF-1 and IGF-BP3 is one of the biggest binding protein hormones for growth hormone. So it's very important. We need to know this. Where is it at? Where it's level? Because if it's low, that means there's not enough growth hormone circulating around. So we need to work on increasing that. And thyroids, we all know about TSH. It's very important. I look at total and free T3. The reason being is because the total T3 also includes reverse T3, which is an inactive thyroid hormone. We have to look at the free T4, that will really tell us whether somebody is hypothyroid or not. And TPO is what thyroid peroxidase. This is the one that tests for Hashimoto's. So Hashimoto's, to me, is an indication there is an inflammation going on, and that's why vitamin D can try to help bring that down, because vitamin D is an anti-inflammatory hormone. Really, that's what it's for. ACTH and the relationship with the cortisol. If your cortisol is high, you got to look at where it's coming from. And then the sex hormones, that is part of the endocrine panel. And so the sex hormones consist of LH-FSH, that's coming from your pituitary gland. And we look at your pregnenolone, not just your progesterone, because pregnenolone is what we call the mother of all hormones, and that makes progesterone. And that also becomes DHEA. We look at the free and total testosterone, because total testosterone is really a combination of DHT and the free testosterone. And then we look at estradiol as well as estrone. Estrone is the bad estrogen that causes all kinds of issues like diabetes. So, and then the sex hormone binding globulin. You will notice sometimes that maybe their total testosterone is high, but their free T is low. Well, it has something to do maybe with the sex hormone binding globulin, and you can find that in people with say maybe some liver issues. So I know this is messy, and then so it's like, how do you remember all this? I don't, until I manage to look at a sex hormone cycle. So everything comes from cholesterol. This goes back to why I think it's not good for people to have low cholesterol, because it makes hormones, as well as it makes the lipid layer that comes around our brain cells. So it's protected. So if you starve yourself of cholesterol, you're going to have things with like hormonal deficiencies, as well as depression, because the brain cells are not that healthy without cholesterol. So let's go through here. Cholesterol becomes pregnenolone. This is why I say it's the mother of all hormones. And then pregnenolone becomes progesterone. And then if you look at pregnenolone in the center, and it becomes 7-hydroxypregnenolone, guess what it becomes? DHEA. And from DHEA, you have androstenedione, but then that becomes testosterone. And testosterone will break down to DHT, and then it would also break down to estradiol. But there's another thing here that we need to be concerned about. That's why we check these things. Androstenedione becomes estrone. So now, knowing where things come from, I think now we understand the cycle better, and hormones, especially sex hormones, learning about them, modulating them is not as scary. Because if you just know these things about each one of them that we look at in biomarkers and think about this picture, then it all makes sense to us. So let's look at, the 5-alpha reductase. There's medications that kind of stop that to decrease DHT, because DHT is what's known to people have high risk for BPH. And then let's look at this aromatase, and then people often give what they call Arimidex in order for the testosterone to not become estradiol. especially in standard hormone therapy. But guess what's going to happen? If you're going to block this T becomes DHT. DHT, however, is one of the strongest testosterone form. However, it's not good in long term, not good in high things, because it does cause a propensity for depression as well. So you want to keep it around the testosterone, have that balance. Okay, so what do we know about testosterone in terms of low T? You can have depression, you can have anxiety, memory issues. Very important, we check this testosterone level in a young male who just came from the service, who you may have not known whether they had a traumatic brain injury or not. Doesn't even matter. If you have a young male in front of you complaining of depression and they've been through all the medications, you better be checking their testosterone, because you would be surprised at what you can find. And I'm finding that it's not just traumatic brain injury that causes this. It's just our environment. It's just the trend that's happening in the testosterone level as we go longer in life or decades. It used to be much higher back then. Now it's a lot lower. And I'm sure Dr. Liu would have an idea why this is happening. Okay, so pregnenolone is very important as the mother of all hormones. It stimulates the gamma receptors that causes sedation, improves sleep, reduction in anxiety. It improves cognition because this will promote the white blood cells to start eat up the amyloid plaques in the brain, so it decreases the risk of dementia. So these are the things that I order: genetic testing, and then my brain well panel includes depression, includes a neuroendocrine panel, and hormones. So the organ of interest, we have to just remember, though, why we do these things and why we call it the Brain Well program is because we have to understand mental illness is multifactorial. Genetics, environmental toxins, trauma, physical or psychological, you can have the same genetic markers that'll show up. And if you didn't know whether they had a head injury or just psychological trauma, you won't know because the markers are the same. And nutritional status, vitamin deficiencies, and those things can affect how a patient feels, and hormonal issues, obviously, that you can see. And this is why my mentor, Dr. Mark Gordon, always says it's not treatment-resistant depression until you look at the hormones, because you can run your gamut of psychiatric medicines, but if you're not checking the hormones, then you're missing a big piece of the pie. Why somebody is feeling depressed or anxious or losing their memory and so forth. So we have to focus on brain health. And knowing all these things, knowing that these are causes of mental health issues is multifactorial, then we can focus on these things and focus on the regimen that will get the brain healthy. So in a nutshell, this is part of the beginning of the Brain Well program that includes genetics, that includes integrated medicine for mental health. As we can see, now we know what labs to order, because that'll guide us on whether a patient is going to respond to TMS with or without supplements, as well as I can look at the genetics. And as we talked about the COMT gene, that's why I'm not surprised whether if they're running like low metabolism of it, why their estrogen is high. So, so when it comes to even directing people with HRT, I use my genetics, so I'm not that cavalier in boosting up somebody's testosterone, even if it's low, because you run the risk of increasing their estradiol way too high. That also then causes problems like anxiety and mood instability. So that is all I have in a nutshell. So anybody interested in looking at, some of the things that I would say how things look like. I think we all know what Genomind looks like. I think we all know what GeneSight looks like, but this is I don't know whether this is going to show up. Let me see if this is a sample report. It's very intimidating. Let's see if I can do this. Okay, yeah. As you can see, this is like not only genetic and psychiatric issues. This will go through all your vitamins, weight management, and so forth, cognitive. So it is very complete, very hard to read. However, if you're looking for certain things, it is there and more. So like I said, this is all free from the company Pure Genomics. Anybody who has a 23andMe and Ancestry.com genetics, it can just be fed into this and you will have this type of report. So it's a lot. As you can see, 42 pages. We're not going to get on into it. Okay, so the other thing I wanted to just look at is, okay, here we go. The two genetic companies that I've been using is Vibrant Wellness and Mosaic. Here's a sample of Vibrant Wellness. As you can see, it has this right here is the, these are mycotoxins, mold. And these are the heavy metals. And you can see there's also the BPA in there, okay? And then somewhere in here, there is glyphosate. But that is what a Vibrant Wellness looks like. And you can ask me personally, like how much it costs. For me, it's very much worth it, especially if somebody is struggling with quote unquote fibromyalgia symptoms and all their doctors say they don't know why. So we have to look at environmental toxins because as explained, the BPA is very, very toxic to the brain, okay? And some of these other ones is Mosaic. This is what used to be called Great Plains. So this is what theirs looks like. Theirs are, you know, obviously they're a little bit easier to read, but it's not as complete. But if I can, you know, pretty much order this in the mail because we're not worried about them with BPA. But, you know, if the female is concerned, and, you know, it's really not that much of a difference in pricing, but it's worth to know everything what's going on with a person. Anybody has any other concerns or questions, you know, be free to email me, text me, whatever you want to do. All right, so thank you, everybody. It's a pleasure, everyone. I will see y'all next time. All right, bye-bye.